Ready now?
Yes, ma'am.
Good morning, and welcome to this month's edition of Oak Hill Regional Community Development Corporation Third Wednesday Parent Resource Chat. My name is Bettina Campbell, and I'm the Social Service Coordinator, and I will be your moderator today. And I'm also excited to announce that I have a wonderful co-host today, and Sister Mary Fenner, who is one of our Medicaid application administrators, and she's also the co-host of Ask Mary, Ask Pat. We are both certified CMS navigators for Oak Hill Regional Community Development Corporation, which is the parent corporation for Healthy Kids Mississippi. We also have with us today Mr. Thomas Duke Robinson, our technology metrist and director, and we are so excited to have two wonderful guests that I will talk to you more about. But before we go further, I want to make sure that I recognize our board chair, Jennifer Garrett, and our executive director, Dr. Michael O. Miner. In addition to this Zoom chat, we are restreaming today's webinar on our Oak Hill Regional CDC and Healthy Kids Mississippi Facebook page. Feel free to share your social media pages. Now, each month, if you've been with us, you know that we try to highlight some national health observers that aligns with the mission of improving the health of the residents throughout the state of Mississippi. In September, we are raising the awareness about childhood obesity, sickle cell disease, NBC USA Hopes Senior Recognition Sunday was this past Sunday, September the 15th, and NBC USA Hope Sickle Cell Sabbath Sunday will be September the 22nd, so today we've chosen to increase awareness about sickle cell disease and sickle cell trait for children and adults, to call attention to the unique health needs and wellness that are challenges, as well as challenges for HIV prevention, testing, treatment, and cure among our people who are aging. So those are the things that we will be highlighting on this webinar today. Mary?
Yes, good morning, everyone. But before we start our discussion, we encourage you to please share this webinar on your social media platform. Then make sure you have your pencil and paper ready to write down your questions, concerns, as we will be sure to save time answering any questions you may have about the presentations. We have with us today Dr. Patricia Adams Graves, who is the current professor emeritus in medicine and hematology at the University of Tennessee Health Science Center in Memphis, Tennessee. She was also the medical director of the historic Diggs Cross Sickle Cell Center, the nation's oldest center, founded in 1929, dedicated to the study and treatment of sickle cell disease, and Ms. Sydney Bradford, a health educator with the Genesee County Health Department in Flint, Michigan. First, we will hear from Dr. Patricia Adams Graves. But first, a little more about this awesome Black woman. Dr. Adams Graves has been a professor emeritus in medicine and hematology at the University of Tennessee Health Science Center in Memphis since 1993. She was the medical director of the historic Diggs Cross Sickle Cell Center, the nation's oldest center dedicated to the study and treatment of sickle cell disease. The center was founded in 1929. Dr. Adams Graves earned a BS in biology and in medical technology from Tennessee State University. She then obtained her medical degree from the University of Louisville in Louisville, Kentucky, where she remained for an additional 3 years for internal medicine residency. She continued her medical training by completing a hematology oncology fellowship at the University of Tennessee, Memphis, where she also participated in additional fellowship at Veterans Administration Hospital, Baptist Memorial Hospital, and St. Jude Children's Research Hospital. In 2004, Dr. Adams Graves implemented the first sickle cell disease specific hospital unit in the nation and a computer education curriculum for the nurses who deliver SC care utilized across the nation. Dr. Adams Graves holds numerous publications in various journals concerning issues surrounding sickle cell disease and has delivered numerous presentations in various venues, including governmental agencies such as the National Black Caucus annual meeting and the FDA. The National Institute of Health has selected to serve on national sickle cell research boards, and she has chaired research sessions at local, regional, and national sickle cell meetings. She is a member of various professional organizations, including the American Society of Hematology, Bluff City Medical Society. Dr. Adams Grave is also an inaugural board member and chairman of the Sickle Cell Foundation of Tennessee that offers social services to adults and children living with sickle cell disease in Memphis. Recently, a scholarship in collaboration with the Memphis alumni chapter of Delta Sigma Theta and the SCFTN was established in her honor. This scholarship will provide senior high school students living with sickle cell disease financial support. As a hematologist oncologist who has served for over 30 years and who also has family members who suffer from the disease, Dr. Adams Graves is passionate about sickle cell disease. She is committed to serving as an advocate and is excited about the endless possibilities ahead in which she will have the opportunity to continue the fight for social justice and health care equality, especially for those living with sickle cell disease. Patina? Dr. Graves?
Just a moment, Dr. Graves is in the process of trying to log on. She had an emergency and she's now in the process of trying to log on. So I'll be right with you. I'm trying to help her get in.
Okay.
She's connecting, so just a second.
Okay.
We know when we have emergencies, those of us who are parents, we know when our children need us or our family needs us as women, we are the first ones that called on. So we're going to go. And it got confused as to what time we were supposed to be on, and she's logging on now.
Okay.
So very excited about that. I'm excited to hear what she has to say about all of the new treatments that they have and prevention that they have for keeping people safe. There she is.
I'm my daughter. I'm Kylie Graves. We're okay right now. So when you call, thank you for calling because it just went totally out of my head. So thank you guys very much for inviting me to be a part of this webinar. My daughter may have some of my PowerPoints on her computer actually, but I had a video I wanted to share, and I started to bring my laptop in this, that I, always want to be ready. So are you guys ready to have a little conversation about sickle cell? It is an easy thing for me to do. I don't have pictures, but I know that you could get a lot out of what I have to say. I do have a PowerPoint on my iPhone, Patina, that I can send to you guys. Maybe, I don't know if it will, it might be too big. I'm not absolutely sure. But I do have some stuff on my iPhone as a picture to share with everyone.
You can try sending it
I'm gonna try to
and
do it.
are you sending it to
Yeah,
me or
yeah, I
okay,
have,
and I'll just forward it to our technology director.
right. I don't know if the video will come over, but I will say this. First of all, sickle cell is an inherited. They're born with this condition due to a single mistake in the protein uh, that is hemoglobin in each red cell. This protein is responsible to carry oxygen all through the body. And so there are 1 in 400 African Americans are affected by sickle cell. Now, the myth is that sickle cell disease is super common, but it's not. If you look at HIV, if you look at diabetes and cancer, there are millions and millions of people living with that. Okay, but in America, listen very closely. There are only 100,000 living with sickle cell disease. Um, so it's considered a rare chronic condition. The definition of being rare is less than 200,000. So they only have 100,000 living in America. Now, there are millions and millions of sickle cell individuals in Africa, okay, Saudi Arabia, and those areas there, but not in America. So that's why the voice is weak. We don't know enough about it. But now, due to this single mistake in the protein that codes for hemoglobin, the cells become what you would call crescent shaped, but they're all sickle cells, whether they're in that shape or not. These cells, red cells, are very sticky and stiff and don't traverse blood vessels very well. Matter of fact, they interrupt blood flow. So wherever there's blood flow, there can be an interruption. The manifestations that occur due to this single mistake is anemia, because those cells only live 14 days, where our cells live 3 months, 120 days. So all the individuals with sickle cell are anemic. They don't have enough cells to carry the oxygen, but they make enough blood cells to keep them going, but they're tired. A lot of individuals with sickle cell are tired because they don't have as many blood cells as you and I. So they make blood, but the blood cells do not live long in the circulation. So they're all anemic because of the blood interruption. So let's go down by numbers. 1, they have profound lifelong anemia. Okay, the anemia that I just discussed is too few cells. They don't live long enough. And then 2, they have pain. So they'll have pain crises because of the interruption of blood flow from these same few cells that circulate. 3, they have a lack of a certain type of immunity that will fight certain types of bacteria. And 4, they have this daily inflammation of the blood vessel wall itself. So they have sticky cell, not enough anemia. They have the inability to fight certain bacteria called like the pneumonia, strep pneumonia. They have inflammation daily, 24/7, but they don't have a crisis, but that inflammation is there and ongoing. And the most important thing that keeps them coming into the hospital emergently is the pain. And if you think about, the pain is due to an interruption of blood flow, think about that. It can result in organ damage. It could cause stroke, kidney failure, liver failure, blindness, skin ulceration. So I have pictures of all these, and I'm in pain to know that I can't show you these pictures because I'm not home. But I want you to know that these folks have a challenge. Okay, so we have 100,000 in America. They manifest, as I just said, anemia, vaso-occlusion or interruption of blood flow due to the sticky cells, pain, organ damage, immunity is, impaired, as well as inflammation. So what do we need to know about them as people? They're very strong people to have to endure this. The life expectancy is shortened due to their condition by about 30 years. Most individuals, now having said that, I want to say to you, I'm not God. I cannot predict anybody's demise, when and how, for sure, but I promise you the vast majority of patients statistically will not make it to age 50. And now we live in our 70s and 80s. Also, I want you to know that because I'm not God, I work for God and help the people. I had a patient who was 80 years old. She passed, I think, just when she was about 81 years old. As a positive note, she lived in Mississippi. She lived in the Delta. She helped take care of her mom. So she had interruption of blood flow in her bones. So she had the sickle arthritis with shoulder destruction and hip destruction and had to have a shoulder replacement. And that's one of the complications. And I have pictures of that. So the lifespan is shortened. So how do we really deal with the children? The children do good, and as they get older, they have more and more problems. So as they transition from pediatric centered care to adult centered care, that's the vulnerable group, ages from, I'd say, 17 to about 22 years old, that group. What they do is they go crazy, just like everybody else young. They want to party and drink and sometimes smoke weed and do all that stuff. And don't you be judgmental, because if you think about it, most of you guys, when you were young, if you're not young now, have, indulged in things that you weren't supposed to. So they use the emergency room as their primary care doctor. Instead of taking their medicines or whatever they need to do, they go to the emergency room and they're in pain. They might have gotten dehydrated from drinking alcohol at a party, or they just had an unpredictable pain crisis. So this pain, the bad thing about pain is you're sitting there minding your own business and bam, all of a sudden, blood flow is interrupted somewhere. It might be in an arm, a leg, and it's extremely painful. That takes a minute. So we have that group that we deal with, and we're doing better with it. We're trying to do a purposeful transition. And of course, we're always concerned about all of the patients, but that's the vulnerable group. The children are under the parents or caregiver where they don't have a choice. They're going to take their medicines. They're going to go to school. They're going to do what their parents tell them to do. So that's another group that we're focused on heavily. Well, let's talk about how you would treat sickle cell, and is there a cure? So most of what we do for the patients is supportive care. Because the sickle cells are more dehydrated, we like to do home regimens, which is drinking a lot of water. So we have them drink a lot of water. We have them make sure that they stay away from sick people. They have to take their medicines. If they want to, they can brush the site that's painful with a hairbrush or something like a TENS machine. The last thing I'm going to tell you is that with treatment is that when they're bad and in pain, they go to the hospital, they're mistreated sometimes because they need narcotics or opiates. And a lot of providers are uncomfortable treating patients and administering pain medicine. So they suffer, have to wait in a waiting room. They're misunderstood as drug seeking, drug addicts, etc. So that's another conversation. Another fight is the bias. Once they're in pain, 22% of deaths is preceded by a pain crisis. So we definitely need the caregivers to give it up and believe when the patients are hurting. They're young. If you just live to 50 and you're a person of color, you don't have the wrinkling and all of that. You look good on the outside. It's the insides that you don't look good at. So in the hospital, they have to have IV pain medicine. If they get infected, they have to have IV antibiotics because they can get a blood infection. They lack the immunity to certain bacteria. And just rest. Sometimes they'll need oxygen if they develop a pneumonia. That can be a fatal event if not properly treated or a delay in treatment. So now we do have, the point is, when they go to the hospital, they can be in there anywhere between 3 days or 6 weeks, depending on the extent of the situation. If they are infected and have a crisis, did they have a stroke? Do they have acute organ failure? Whatever. So we do have a cure now. We've had the bone marrow transplant for well over a decade and a half. It's not available to everybody. You have to have a sibling match or at least a half match. And if you don't, then you can reject the transplant, but it is a curative procedure. We now have CRISPR or gene editing. Actually, a young lady out of Meridian, Mississippi was the first recipient of CRISPR and it worked, it saved her. But it costs $2 to $4 million, so it's very expensive. And it's not available, obviously, for everybody because it's a month-long, hospitalization along with all the other stuff. And the procedure is intense, as with bone marrow transplant, but you don't need a sibling donor. You don't need a donor. You serve as your own donor for gene editing. What they do is take your own cells out, the baby cells, and they edit it out just like you type and make an edit. You could do that with genes now. So they do that and correct the sickle gene. And they put it back into the person so they don't have to worry about rejection like you do with bone marrow transplant. So who's going to pay for that? So that's another fight. I want to end it with that. I also have this condition in my family, so I'm very passionate about the severity of it and the improper treatment. It still goes on, but we're doing better now. And I didn't want to, because I've used up most of my time already, I at least want to end with that this is a painful genetic condition and it can affect the body anywhere there's blood flow. So if you think about that, where do we not have blood flow? Even you can lose hair, you can lose nails if not treated. But we do better. We educate our patients. We advocate for our patients. And now I'm chair of the board of the foundation. We're having our 5K coming up this Saturday at Marquette Park. Unfortunately, we're the only foundation, I believe, that pays for burial support because of that 30-day gap. But we do have sickle cell individuals who are very successful. They make it through college. I'm not saying it's everybody, but it's a large proportion of our patients have these interruptions of life and barely make it through school. They can't hold a job. The probation, barely make it through 3 months on a new job. And it's difficult. And so with burial support, they cannot get insurance. They can't get life insurance. So who's going to do that? So we do that. And if you want to participate, you can come out Saturday at Marquette Park. We'll be out there at 7 in the morning. That's open enrollment, or you could register or just come out. We have a few vendors. Some of our sickle cell individuals sell things that they make. They like to be called warriors, so they make warrior bracelets. And I haven't missed a one, and my husband and my family. So we're going to walk 5K. It starts at 8 o'clock. If you want to join us, come on out. And I definitely apologize, but when your family need you in an urgent situation, all things go out the window. And I don't know why I was thinking, well, I'll swing back at 4:30. I probably have something else at 4:30. So my apologies, and thank you so much for being patient. And Bettina, I can follow up and send you some information that you could share with the group, pictures and etc. Thank you.
Thank you so much, and we'll make sure that we put them on our website. I think we also already have the flyer that you sent about the walk posted on our website. And we certainly encourage individuals to become involved and engaged in this. Unfortunately, I myself will be out of town, but I'll try to remember next year so I don't schedule anything that we can walk. It's very important. And as you said, because there's so few people who have it, and most people of color are people that have it, so that's the African American or Hispanic or other people of color. So we want to give our support to them, and those of us who have individuals in our family who suffer from sickle cell or the sickle cell traits, we know what they go through. And so we want to do everything that we can to try to help promote a cure for sickle cell. And if not a cure, at least something that will make the pain less and more tolerable, and also make the lifespan longer. So again, we understand, I for one understand, and I'm sure that the workers, when you have family that, especially our children, when they need us, they need us. Everything else goes out the window. So we thank you so very much for you being with us today. Now, there's just one other question I do have, is that how can we get involved, other than the walk, how can we get involved in this awesome work?
Well, Jackson, Mississippi cares for quite a few patients. Some of them come to us, but you could reach out to the foundation. I forgot the name of it in Jackson, Mississippi, since you're in Mississippi, or you could flip over to us. That's fine. You have my information, and I can connect you guys with our CEO. Our CEO actually lives with sickle cell, and our communication secretary also has sickle cell on our board. There's always room to volunteer. We have plenty to do. So we had a blood drive. You can have blood drives. We had our blood drive at Lemoyne College because blood saves sickle cell lives. Because one of the treatments is transfusions of blood exchanges for those emergency strokes. And some of our patients have to get blood every month. And then before I retired, we used to transfuse 100 pints of blood a month just for sickle cell. So be a donor, be a blood donor. Don't be afraid. I see all those tattoos. So don't be afraid of the needle, y'all. And it's sterile, but become a blood donor because you match better than the Caucasians, but they match too, but just less frequently. But Caucasians donate more than we do for our own people. So become a blood donor, contact the foundations, volunteer once a year. You could probably just give 2 hours do something, whatever is needed at the time. And our one staff member, Miss Rufus, she's 80 years old now, and she's there for us. So she's always looking for some help. You can answer the phone. So there's a lot to do, but Mississippi has a foundation as well. And I don't want to take out of your state because, you want to serve the people in Mississippi first. And then you could cross over in our area too, if you want.
That would be rather easy for those of us who live in South Haven. So to do both. So, all right. So again, thank you so very much. And we hope that you're able to stay with us because we will open up the mics or we take questions off.
I can stay. But I do need to check on, let me check on my girl over here. I'm gonna walk away a few minutes.
That's okay. You can just turn your mic off and your camera off, because we're going to be talking with Miss Sydney Bradford next. And as I stated earlier, she is a social worker and health educator in Flint, Michigan. She's been involved in HIV for 20 plus years. And right now she working to ensure that all individuals, regardless of age, race, or socioeconomic status, has accessible accessibility to quality care and valid information and accessible resources for optimal quality life, and especially sexual health. Sydney, a personal side, I have worked with Sydney for a number of years myself, and I know that she lives and breathes this work. She's an excellent person for the community, and she has the heart of the community and has all the work that she does. And so we are so fortunate to have her here. She has a social work degree from the University of Michigan, and she also has a master's of health education from University of Michigan, and she is a certified health education specialist for HIV with the state of Memphis. So Michigan, Lord, I'm always getting that confused, Sydney, since I'm here, but she's in the state of Michigan. So welcome, Sydney. And
good afternoon,
thank you
everyone.
again for not hesitating to accept my invitation.
Yeah, good afternoon. Tina and I have a mutual admiration society going on here. So anyway, thank you for having me, and let's get to it.
All right. So my first question for you, Sydney, since I said that we are, it's a National HIV/AIDS Awareness for Aging, will you tell us why, what it means and why it's important?
Yeah, well, with the advances in effective HIV treatment, people with HIV are living longer and healthier lives now. National HIV/AIDS Awareness Aging Awareness Day was launched on September 18th, 2008 by the AIDS Institute. More than half of the people in the United States now living with HIV are over the age of 50 and over. And that's concerning, which also is a testament to the treatments that are available now, because that means that people are living longer with HIV. This day raises awareness and emphasizes the need for prevention, research, and data that focuses on aging and HIV individuals, and helps us to improve the medical professionals' goal of monitoring and managing the effects of HIV on older people and living with and affected by HIV.
All right, wonderful. So do older people have the same risk factors as for HIV as younger people?
Yes, many risk factors for HIV are the same for people regardless of any age, but like younger people, older people don't have the knowledge and understanding and awareness of HIV. And some of that, I think, comes from the stigma that has been associated with HIV over the years. We know that when HIV was diagnosed, it was basically associated with a specific population of people. And we now know that that's not the case anymore. So in the United States, HIV is spread mainly by having anal or vaginal unprotected sex or sex with someone who is HIV positive. And to note, a lot of people who are HIV positive don't know that they are in the initial stage. So that's the troubling stage that we have, the asymptomatic stage. So people don't know that they're infected because they're not having any symptoms. So they're continuing to engage in practices that don't promote safety and prevention. And sharing injection drug works, needles and syringes also is a way to promote HIV. And here in Flint, where I am, we know that our rates are increasing because drug use is increasing, especially among other drugs rather than heroin, but methamphetamine and some other things that are going on now. So yeah,
I believe at one time, Sydney, we were stating that we also know that because unfortunately some people who use drugs sneak their needles from people who have to use them for medical treatment.
For medical purposes,
and
diabetes,
they're putting them back, and that's how some of them are getting infected. And so
absolutely,
any needle sharing can be dangerous.
Absolutely.
Yes. Absolutely. So my third question is, are there some age-related factors that may contribute to older people's risk that are different from those of young people?
Yes, there are some age-related factors. With women going through menopause, we have a depletion of estrogen, which is mainly responsible for our lubrication during stimulation. And women who have had hysterectomies, they are no longer getting the estrogen that their body was making. And so it thins out the vagina. It also causes atrophy, which is severe dryness, and which can cause tearing during sexual contact. And so women need to be very mindful if they're experiencing those kinds of symptoms, that they need to be talking to their gynecologist or their primary care doctor, someone who can help them to manage those symptoms. We know that older people are less likely to use condoms because they don't think about pregnancy anymore, not aware that that's the least of the issues that they need to worry about. And because of the divorce rates, and older people are single now, but they're still engaging in sexual. So we need to make sure that they have the information they need to stay healthy and safe.
And
And
let us
so,
not forget about Cialis and
but
Cialis.
yeah, the Viagra and the Cialis, and men around here taking it and they're like, we ready, but so we need to be mindful. And another note is, it's important to have a primary care doctor or a gynecologist that you feel comfortable and that you trust enough to have these conversations with, because the doctors are not really talking to us about our sexual health because they're thinking they're older and they're not engaging. And so we need to let them know, yes, we are still vital and active, but you need to have that relationship with your doctor so that you trust them enough to have honest, open communication with them.
I agree, because we know we've tested a lot of seniors, so.
We have.
Yes. So talk to me about some ways that we can, healthcare providers, we can talk to our healthcare provider about reducing our risk.
Well, the CDC recommends that everyone age 13 to 64 and over get tested during your regular medical examinations, your annual health screenings and everything. And you should get tested at least once as part of that routine health care. People are at higher risk of getting tested more often, for example, every 3 to 6 months. So if you know that you're engaging in sexual behavior or you're indulging in other behaviors that can put you at risk, you must get tested. A lot of people say, I don't want to know, but you do want to know, because if you know, then you can start to get treatment or you can alert other people, because you must let people know if you're HIV positive before you engage in these behaviors with them. Or, it's some legal things that come and play with that. And your healthcare provider may recommend an HIV testing if you're over 64 and at risk for HIV. So we just need to be mindful that as part of a regular routine, when you get your blood work done, you can ask them to test for HIV and STDs. Insurance will pay for it sometimes, and sometimes they won't, but you need to talk to your healthcare insurance to let them, to make sure that you have the information so that you know whether you have to pay for it or not. But there are also clinics, health departments, we do screenings and everything without insurance. So there's no reason for you not to get tested. It's easy and it's free in most places. So we want you to do that.
We know that older people don't even think about it and getting tested. And sometimes it's because can you share some of those reasons with us?
They don't get tested because they're ashamed to state that they are still engaging in behaviors. Sometimes they just don't have the knowledge that they should be tested. And so, sometimes your HIV is mistaken in older people for other things. We have other comorbidities that are occurring with us that can mimic HIV symptoms, and you won't know for sure unless you get tested. You can just think it's a cold, or you can just think you just have this cough that comes on. And then when COVID came on the scene, that added another layer that people could mistake their symptoms for. So we need to make sure that testing is done, because that's the only way to be positive that you don't have HIV.
And I read that a lot of them are finding out, older people are finding out that they're HIV positive until they're in the advanced stage. And what does this mean for them?
It means that it's a late start for treatment. It means that treatment is delayed, and so therefore the symptoms may be worse. It may be harder to treat it at first. Studies have shown that delaying treatment can increase the chance that people with HIV will develop AIDS and other serious illnesses. We know that there are some pneumonias and cancers that are associated with HIV and AIDS, and we know that those things can occur if people don't get treatment. And a late start to treatment also increases the chances that you have what is called immune reconstitution syndrome. And that means that there's a worsening of some infections in people. When HIV and low CD4 cell counts begin taking HIV medications, their body can adversely be affected by that, and they may not work as well in the beginning. So that means that they have to try specific regimens or keep trying to find something that works. And we know also that people who are taking PEP and PrEP, which is the drugs to prevent, and people who when they're engaging with people who are HIV positive, those things can also affect a person's body too. So we need to be mindful of getting tested in early so that we know that we can start getting treatment early.
Okay, so by them, are there any other special issues that might affect people with HIV that are older?
Yeah,
in
we
terms of
know that the
treatment?
natural senescence of aging brings on heart disease, COPD, diabetes, cancers, other things. So the effects of from HIV medications and other medications may occur more frequently in older people with HIV than with people that are younger. The increased risk of drug interactions in older person taking HIV medications and medicines for another condition can delay their ability to have treatment be effective at first. So age-related changes that can affect older person's ability to think. Our cognitive our mental states decline, or we may be forgetful, so that people are not taking their medications as they should. And if they don't have a support system, which is vital that we have a supportive environment when we are diagnosed or we're living with HIV, or we have people who are living with HIV around us, we have to be supportive. We have to make sure that they are on track with taking their medications in a timely manner, so that they can have the most effective quality from that.
Okay, very good. What is the first step that a person should take if they think that they may have been exposed to HIV?
The first thing you should do is to get tested. You need to get tested. Don't wait. If you know the signs or the symptoms of HIV and you're feeling anything, you need to get tested. We recommend that you get tested anyway when you're doing your routine blood test. But if you're having symptoms, get tested. You have to get tested. That's the only way to determine positively if you are HIV positive. And then knowing that, you can then know possibly where you contracted it from, because we can start to do partner services where we are getting information from you about who you've been engaging with. And so you got to be honest with that too, so that we can help to minimize any more HIV transmission. And studies have shown that people are not comfortable talking about this still after all of these years. I mean, it's been what, Tina, 40 years, 50 years. We still are not comfortable. But now we can talk about what the stars are doing. We can talk about who's doing what, in other people's business. We need to make sure that we're taking care and making sure that our health is optimum and our first priority today. We need to do that.
Yes, we do. And I know I said that would be the last question I asked you, Sydney, but I'm going to throw this one at you.
Okay.
I know that you can answer it. A lot of people think that HIV and AIDS are the same. Is there a difference?
There is a difference. HIV is the first stage of AIDS. You have the asymptomatic stage, which is when you have no symptoms at all. It can go up to 6 months. You can have no symptoms. It can go longer. It can go to 10 years. You can have no symptoms for 10 years. And then all of a sudden you're getting these things, and first thing you don't think about is HIV. You think it might be something related to your age or something else. That by that time, we may not be able to be as effective, and you may have infected other people, because if you're not in a committed relationship and you're engaging in sexual behaviors with multiple partners, you very well could have infected a mass of people. AIDS is the last stage of HIV. And when you get to the last stage, you are in a state where your body is, your white blood cells are completely depleted, and you are not able to function. You're getting some other illnesses, maybe pneumonia, your respiratory system is affected, your whole body is being diminished. And it's harder for us to treat that. But now people can come out of that stage. You get treatment, you can come back out of that stage. But you must get tested initially so that you know whether you are HIV positive. We have to do that. And we have to promote that.
So then what I'm hearing you say is that HIV is the virus and AIDS is the symptoms of the virus.
It's the symptom of the virus, absolutely.
Okay, so it's not wise, it's not, you shouldn't use it interchangeably because it's not the same.
It's not the same thing.
And
No.
Sydney, you have been so wonderful today.
Thank you, Tina.
I'm sitting here so proud.
I appreciate you, girl.
I'm sitting
You
here
know I'll
so
do anything
proud of
for
you.
you. Anytime
And,
you need me, you let me know.
and
And
I'm
I'm so
very,
happy, excuse me, Tina, I'm so happy that you have this forum because this brings awareness about the issues that affect African Americans specifically, but people in general, to the public. We need to know that there are people out here like you and Ms. Fenner and Dr. Graves and all the other people who are actively on the front lines trying to change the thinking, because if you don't change the thinking, you can't change the behavior.
and that's what and that's what all health is about, behavior.
Absolutely. If you know better, you do better, hopefully.
I was even surprised to find out from my son when he talks about cyber security, he said it's a behavior.
It's
And
a
so
behavior.
all of it is behavior, and
It
we
is.
have to know how to prevent behaviors that put us at risk. And we are so happy that we have this ability to be able to bring this information to people. And although we know primarily people in Mississippi who we are reaching out to, we know that our broadcast goes way beyond Mississippi. And so we are excited and we are happy about that. And I also want to say, since we started working with this disease way before there was any type of effective treatment, it's heartwarming to know that if they do get on the regimens, the PrEP regimens that you were talking about, that people can live a lot longer, because before they're getting a diagnosis of AIDS today, they were dead tomorrow. And so now it's so much longer, and I'm so excited.
And it's also heartwarming to know that a lot of people have let that stigma surrounding HIV go, and they are having the knowledge and awareness that you can have a relationship with a person who's HIV positive. There's things that you need to do, but their quality of life is wonderful. It's just heartwarming to know that we've come so far with the treatments and with the attitude about HIV today.
So there is no excuse for not getting tested and knowing your status. That's the key.
Absolutely.
Get tested and know your status. So please share this information. Mary, I hope this moment, Mary. I hope you're able to stay around and answer questions in case someone has questions, Sydney. Thank you.
Okay, Dr. Graves and Ms. Bradford, thanks so much for this very valuable information and resources. We definitely appreciate both of you for taking time out of your busy day to share this much needed information with us. Is there anything else that either of you would like to share with us?
I just thank you for having me. I appreciate that. And I'm going to make sure that this is every third Wednesday of the month.
Yes, it is.
That I'm going to try to, Tina, can you send me a link before the webinar so that I can at least try to participate or ask questions or get some information?
Yes, we'll make sure that I'll make sure that I get that. I do that.
Okay, I appreciate that. Thank you, everyone.
Oh, you're welcome.
And
Once again,
I too want to thank you for having me, and I'm so sorry for this debacle. I would like for you to consider inviting our foundation CEO. Her name is Alexis Gordon, and she actually lives with sickle cell herself, and she is our CEO. She would be a wonderful speaker and guest for you guys. She's from Mississippi. She's from Jackson. No, right out of Jackson. What's the little town right outside of Jackson?
Can't.
No, it might be,
certainly
but it's a
don't know,
small.
being a transplant.
It's real close to Jackson. Let's put it that way.
Madison.
No.
Dr. Graves, I'm sorry. I have one question. Do both parents have to be a carrier, or how does that work with a person who's diagnosed with sickle cell? Is it one person?
I'm glad you asked, because that was what I left out trying to, cut time. But let's do it this way. If each of us have 2 sets of genes, and I'm gonna have these fingers up. Okay, so this is the mom, this is a dad. Okay, we have 2 sets of genes for everything, hair color, whatever. So for sickle cell, Each of us has a hemoglobin that's normal, okay? Hopefully on this line. But if you are born with a normal hemoglobin gene and each parent has a sickle gene, okay? And had 100 children, this is just to put you in a perspective, okay? These 100 children would be broken down like this. 50 of the children will be like their parents and carry one sickle gene and one normal gene. 25 of the children will inherit their normal gene and will be completely normal, more normal than their parents. 25, if they inherit a sickle gene from each parent, okay, they would have the disease, which is, I'm getting disoriented, which would be about 25 of the 100 children, if that makes any sense to you at all. So each birth, there's a 1 in 4 chance of having inherit sickle cell disease from the carriers. But there are a lot of scenarios. There are people that have full-blown sickle cell, 2 S's, sickle cell genes. And if you have offspring with somebody who's completely normal, 100% of that combination would have trait or carrier. They would inherit the 1 sickle gene from the parent with sickle cell disease, and then 1 of the normal genes from the other parent. If the parent of this 100, let's say they would have someone that was a trait who had children with somebody with sickle cell disease, 75% of those children would have the disease, and only about 25 of those 100 would be carriers, but nobody would be normal.
Okay, so is there a test that parents can take before having children to determine if either one is a carrier?
Yes, ma'am. You could get it done free, a screening at least, if you are a blood donor, African American blood donor. They will do trait testing on you. We do trait testing through the foundation at our church homes and various venues. And the test is called hemoglobin electrophoresis or fractionated hemoglobin. And it will break down if you have the trait or one of the conditions, right?
Mhm.
But by the age of 7 months, if you have the severe SS, you're gonna know you have it because you're gonna start having symptoms right at 4 to 7 months of age.
Okay.
If you're one of the lucky ones and have a severe type but less severe, then you could go throughout life like HIV and not know you have it until you have a complication. So yes, it is inherited, and you need to know your sickle status and get a fractionated hemoglobin. You can ask, can you screen me for sickle cell? I think I have it in my family. Can you screen me? I'm completely normal, but I have 2 cousins with it.
So we need to be promoting more awareness with young people about getting tested before they actually start to have children.
Well, now, unlike us, we have newborn testing.
Oh, okay. Okay.
So you don't have to be as intense about it, but the deal is they get lost to follow up. So once you diagnose somebody that has it, then sometimes they change their phone numbers, their addresses, and they still don't know they have it.
We have that problem,
But
Tina,
their
right?
newborn testing, you need to be aware of. What you tell them is they're going to test you. So
Right.
be sure you keep in touch with the birth center and your doctor so they can tell you the results. And they will not know the actual type of sickle cell because there's SS, SC, S beta plus thou, S beta plus 0. They won't know the type until they did the fractionated hemoglobin. So at birth, they're still looking at the baby hemoglobin or the fetal hemoglobin. So that's an excellent question. Thank you. This works out real well.
Thank you.
Okay, you're welcome. We're going to have more question and answers at the end. But once again, we encourage you to share today's webinar in your social media network. Feel free to post questions or comments in the Zoom chat or in social media comments. We will do our best to respond to each question. Okay, but before we get to our reminders of upcoming events, we have launched a very special program, Moms. And Sister Lori Rogers is going to come on, and with her team are here to share just a snippet about this amazing resource.
Good morning. Can you all hear me?
Yes.
Okay, great, great. Good morning. It's good to be here this morning. I am going to share, some of the team members are here and available. We have this new initiative that we are working on called Moms, Maternal Outcomes Made Superb. Moms is a growing regional effort for maternal outcomes made superb, understanding that motherhood is a lifetime commitment. Oak Hill will be striving to help mothers and their children make the best possible start. For these families, we are focused on raising the quality of their health care, connecting them with health coverage, and helping them meet social health needs. So we are very excited about the kickoff of this program. We will be sending out more information. You will be seeing information on our website. We will be having educational opportunities to share with our moms. We are focused on strong maternal health outcomes. And we'll be doing training, education, and walking moms through this process with their maternal. We want positive maternal outcomes. So we will be sharing that information, activities, and we are just getting the word out. And prayerfully, this will be a strong, I want to say ministry because it is ministry, but it will be a strong initiative and we'll have the great results and the outcome that we desire. Thank you.
Thank you so much, Lori, for that information about the Moms piece, that the new initiative that we have started here at Oak Hill. But just a friendly reminder, Ask Mary and Pat Zoom webinar will not be held on Monday, September 26th, 2024. However, if you have questions, please feel free to call 662-298-3584. Let's talk about real estate with area. Mays will be held 11 a.m. September 26th. You don't want to miss this show, as Mrs. Mays will have a real estate attorney to share with you how to stop someone from stealing your deed or house right from under you. Also, our next third Wednesday Parent Resource Chat will be at 11 a.m. October 16, 2024. And we will be talking about pregnancy and infant loss awareness, postpartum depression. Please be sure to join us and encourage friends and family members to listen also, because you don't want to miss this important information. You may learn more about us at www.oakhillregionalcdc.com and www.healthykidsmississippi.org. Once again, we acknowledge our board chair, Jennifer Garrett, and our executive director, Dr. Michael O. Miner. This has been a production of Oak Hill Regional Community Development Corporation, belonging, building, and bridging in the Mid-South region and across the state of Mississippi. Everyone can stay on.
Do we have any questions on social media?
Not at this time.
Not really. Wait a minute. So everyone can stay on. We would invite you to stay on for a few minutes. We're going to sign off social media and continue on Zoom. You can open up your mics and you can ask questions. And if there are any more questions, or you can just make a comment. So